Hello, welcome to this program. My name is June Halper. I'm a nurse practitioner specializing in MS, and I'll be talking with Dr. Fred Lublin about the many disease-modifying therapies that we now have in multiple sclerosis. New and emerging therapies have made treatment of MS very different, but today we want to focus specifically on how we go about selecting and targeting MS therapies. So welcome, Dr. Lublin. It's a very exciting time for us in MS. Many years ago, we were faced with challenges in the disease and very few treatments. But now the disease, which is highly variable, we know so much more about it, and we now have a whole armamentarium of disease-modifying therapies. But before we get started, could you go over the MS pathology and what happens in disease progression?
The pathophysiology of MS basically boils down to looking at neuroinflammation and neurodegeneration. And we know from the pathologists that there's inflammation during the entire course of multiple sclerosis. It's more prominent during the relapsing phases, and that is early in MS, and becomes less generalized and even less focal as you get into the later stages of MS, but there's always inflammation present, which has guided some of our therapeutic strategies. But in addition, there's a neurodegenerative aspect, which may be secondary to the consequences of inflammation, but it may also be a separate process. And that neurodegeneration increases over time and is especially prominent in the progressive aspects of multiple sclerosis. But while we like this dichotomization to think about it, it may be an oversimplification, and there's certainly more going on than just this. Now, the other aspect when one starts to think about treating MS is to look at the disease course. Disease course's understanding is critical for trying to prognosticate how individuals are going, and also for selecting our therapies. Now, we first defined the clinical courses in a consistent way in 1996. And then in 2013, we reevaluated and revised the clinical courses in some ways, although they've been very useful both for clinicians, for clinical trials, and even regulators. And the regulatory aspect actually has caused some confusion, and we'll get to that. But the courses that we now recognize are clinically isolated syndrome, relapsing remitting MS, secondary progressive MS, and primary progressive MS. And you can see that on this table here. So clinically isolated syndrome is the first attack of inflammatory demyelination, which, when it meets the criteria of something typical for MS, which would be like an optic neuritis, brainstem cerebellar inflammatory event, or a partial myelitis, and is accompanied by changes on the MRI, is highly likely to go on to meet criteria for multiple sclerosis in the future. Whereas those who actually meet criteria, as defined in the latest McDonald 2017 criteria, are relapsing remitting MS. Acute attacks, which occur over weeks, months, years, even decades between attacks. But in between attacks, the individual is stable. They may have residual disability, the stepwise worsening of impairment that occurs in relapsing disease, but they don't change between their attacks. Now, both of those forms can be further subtyped or subcategorized as to whether they're active or not active. And this idea of adding an activity time frame was done in 2013. And the reason we did that was to provide a dynamic aspect to the clinical course. Because once you have relapsed remitting MS, you can't go back. So you have that forever. But in any given time frame, the clinician would want to know whether the individual was active or not active. And I mentioned time frame because this is critical. This determination of activity must be framed in time. And we recommended that that time frame at a minimum be annually. But a clinician pick whatever time frame they want, 6 months, 1 year, whatever. Activity is defined as either a relapse or a new or unequivocally enlarging T2 lesion or a GAG lesion, gadolinium enhancing lesion on the MRI. That's active. And either one of those, either the MRI change or the relapse, would qualify as activity. So then either clinically isolated syndrome or relapsing remitting MS could be either active or not active in any given time frame, but you must define the time frame. Now, for the progressive forms of MS, primary progressive is progressive from onset. They never had a relapse coming into disease, but instead gradual worsening over time. Now, after they enter that initial primary progressive phase, they can have relapses, what we used to call the old progressive relapsing phenotype.
Right.
Now that would be primary progressive with activity. Secondary progressive, the other progressive form of MS, follows a relapsing remitting period. And it may be short, it may be long, but it always starts with relapsing remitting MS and then transitions into secondary progressive. And the idea of this transition is that the individuals are worsening independent of any subsequent relapse activity. So they may have intercurrent relapses, they may not, but in between the relapses, they're gradually worsening. And so for progressive disease, you can then time frame the subtyping as to whether they're active and progressing, active and not progressing, not active and progressing, or not active and not progressing, meaning they're stable. And not all progressive disease continues to worsen. It can stabilize over time. But remember, for those determinations, it must be framed in time. And like I said, we recommended 1 year. It doesn't have to be, but it must be defined in time. Because if you take the case of secondary progressive MS without time framing was always active because they had to have had a relapse or relapsing course beforehand. So that's how we characterize those. Now, why is this important? Well, it's important for the clinician and in their communications with the patient, but it's also important for labeling indications. So the vast majority, and we'll go through this subsequently, of our agents are approved for relapsing forms of MS. We only have one approved agent for primary progressive MS. And then we have this confusing term in the label of active secondary progressive MS. And the confusion is because it doesn't time frame it.
This whole armamentarium it can be confusing for a community physician. And this is wonderful that your explanation, I think, will help them. It also justifies the use of steroids, for a relapse, because many people anticipate once they go on a disease-modifying therapy, there are no relapses, and that's that. So I think it's an important piece of information.
Okay, yeah, and we know that none of these medications is perfect, so we still do see some relapses. So here you can see the clinical courses laid out graphically. And the one to pay the most attention to at the moment would be the upper right, the relapsing remitting, showing that there's stability between attacks, but after each attack, in this case, there's incomplete recovery. This is the stepwise worsening, or what's called relapse-associated worsening, that is especially prominent early in the course of disease. And then if you move down to where it says secondary progressive MS, you could see that in addition to the relapses producing worsening, there's also this gradual worsening in between. That's best seen in the green bars, the green lines rather. And then there's periods of stability as well, which are the blue lines. And then primary progressive is just that, worsening from onset without a clear relapse early on, but they can have relapses later, as shown in the bottom right graph.
Yeah. Well, the whole message here is that no matter what, whether it's stability between attacks or gradual progression, there's still accumulation of disability, unfortunately. And that's something we hope that someday will disappear. So what about CIS? I know for years, we were told right at the beginning, you wait for the second attack. But today there's a whole different philosophy.
Right, so there's two different aspects going on here you bring up. One is clinical isolated syndrome. They look like MS, but they haven't met the criteria for a second attack or even the single MRI criteria for dissemination in time and space. But if it's a typical CIS, as I said, optic neuritis, brainstem, cerebellar inflammatory event, or partial myelitis, the data is very strong to suggest that treating them lessens the risk of future attacks. But then there's also the issue of what's happening before clinically isolated syndrome. Well, there's radiologic isolated syndrome, that is individuals who have an MRI scan for some other reason, a bump on the head or a bad headache, and it looks like MS. And if the MRI really looks like MS, there's a pretty good likelihood that they'll go on and have attacks or new activity on the MRI. We're still studying that group. We don't know when or even how to treat them. It just hasn't been studied. And then the other issue that you raised, which is really interesting, is this idea of the MS prodrome. And that is what's happening to people years, sometimes even decades, before their MS expresses itself neurologically. And we may see other things like headaches and psychological issues and hospitalizations. And so there's things going on that we need to get a better handle on that ultimately lead to individuals expressing, the clear neurologic dysfunction of multiple sclerosis.
Yeah. Sometimes the person's self-report can certainly give you a clue about what's going on. On the other hand, you can't MRI somebody if they feel very tired all the time.
Right, so, and that's another point, that the fatigue issue is a good one.
Right. So what did the disease courses tell us about treatment? What clues can a clinician look for when they start thinking about treatment selection?
Right, so certainly when I talk about treating the CIS based on the data we have from multiple studies, the reasoning for that is the earlier we treat, the better people do. And the longer we wait to start treatment, the less well they do. They've accumulated deficits. We don't have ways of reversing the damage that's done on individuals. There's a certain degree of natural healing that occurs, but after any relapse, you can have residual, and about 50% or so of attacks leave some kind of residual dysfunction. So the earlier we treat, the better people do. The constraint we have right now is that our treatments are all anti-inflammatory of one type or another, immunomodulating treatments. And so they're best treating the early relapse-based impairment that we see. And treatment of the more gradual progressive form of disease is a major unmet need because our therapies just don't impact it to the same degree. I mean, we can turn off gadolinium enhancing activity and relapses to a major degree, down to the point where you're seeing, one relapse every 7 to 10 years. But we're not as good yet at treating progressive disease.
The one thing is we were concerned about, with patients, many patients now are choosing treatments and coming into clinicians and saying, well, I heard about thus and such, I was at a support group, or there was an ad in the People magazine. How do you handle that kind of situation?
So the good news about MS is that we have so many therapies that we can treat individuals with, certainly for relapsing forms of MS. And as I said, the earlier we treat, the better we do. And you can see on this chart here, we have lots of therapies, injectables, orals, infusibles. And just today, there's a new approved agent, another S1P1 modulator called ponesimod, which adds to the number of S1P agents that we have. And so ideally, a clinician would be facile in utilizing all of these agents. That may be a lot to ask of community neurologists who are burdened with knowing how to treat, all of the various neurologic diseases, not just MS, like those of us who specialize in this. But one can become familiar with the various types of disease courses, the mechanisms of action like S1P1 and anti-CD20 affecting B cells and T cell inhibitors and such. So there's lots of choices. And we don't have time today to go through how you would do that. But the main principle, June, as you're aware, because you've been a proponent of this for a long time, is shared decision making with the patient, where to sit down and get an idea of what their risk tolerance is, what their concerns are about safety, what their lifestyle issues are, what their family planning issues are, and going over, the benefits and risks for any given individual. And so the clinician's job is to talk about relative efficacy, how it's going to affect them, what the requirements are for taking that medication in terms of, contraception and follow-up and monitoring, and how often the therapy is administered. And then the patient will report back and want us to pay careful attention to this, well, how they feel about the safety, what's known long-term, what their family planning issues are, what kind of follow-up they can do, how often they can go in to get the therapy, if it's, for example, it's an infusion, how they feel about self-injecting. So it's a long conversation, probably takes about an hour. And this is why we, and as part of the AAN recommendations and such, usually do this in 2 visits. One visit where you discuss the diagnosis and the implications of that, and then a second visit to come back and have this discussion about disease-modifying therapy.
Yeah, because ultimately the patient really has to take it on. I mean, they have to do the follow-up if there's blood work, and in preparation for the commitment for a long time, lifelong disease is something that, say, a 22-year-old is just not expecting. In our world, we have a headache, we take an aspirin, and then you feel better. And the commitment to MS is quite a substantial one.
You're absolutely right. And this is why it takes time to sit and discuss that, especially at the time of the diagnosis, which is why we put off the treatment discussion, so that people understand. Now, with all of these therapies that we have now, we take a very optimistic approach that we can control relapsing forms of MS. Patients are often concerned when they come in with their first attack, do they have progressive MS, because they heard that's the bad type and such, and we counsel them about that as well. But I take an optimistic view, because I think with our agents now, we can control this disease really very nicely. Although we still could do better.
Well, that the thing that always scared me, is how do you tell a patient that they don't have a relapsing form of the disease? And, everybody is learning about those drugs that are for relapsing MS. And in your lap is this responsibility, and it must be really particularly difficult for you.
Well, we can lay it out for people. I mean, we've gotten good at it. We have a whole staff that talks to them, not just the clinicians and the nurse practitioners and the social workers. And I think that having that kind of support available and knowing that they've got backup and can get their questions answered provides, some comfort. Sometimes it takes a little time. I tell individuals, look, you're going to feel badly about this, you're going to worry about this, but as time goes on and nothing else is happening to you, you're going to put this farther and farther back in your mind and go on living your life as you normally would, and which is what we plan for them to do. I
agree, but it does take time. I mean, this is not something that you can just snap your fingers and it happens. And it's a difficult thing for a patient to absorb, especially most of our patients are fairly young.
Right, and some of the impressions that are out there are worse than what the disease actually is, and that's a part of the counseling too. Because they come in and say, "Well, how soon am I going to be in a wheelchair?" And in fact, with the modern therapies, that's not very common at all.
Yeah, well, that's the one thing we have to overcome. While we know that a wheelchair is a good tool, that's still that if you ask patients to close their eyes and you say the word MS, wheelchair still does pop into their head. Yeah. So I think we do have to take a much more proactive and more of a modern, positive approach to the disease.
So one of the things that we think about when we're looking forward to MS, our goal is no evident disease activity. I mean, we want to get rid of relapses, we want to get rid of MRI activity, we want to stop worsening and progressive disease. It's an aspiration. None of our current agents can do this entirely. We can look at percentages and we're getting better and better. And some people think it's an unattainable goal. I'm not sure that's correct. This idea of disease activity free. We certainly have gotten very good at limiting GAD lesions, really uncommon with our common highly effective therapies, and relapses, again, uncommon. Progressive disease is still something we need to get a better handle on. But that's the light at the end of the tunnel, is that we can turn off the disease activity completely. My guess is we're going to need additional mechanisms of action to achieve full success.
So when a patient comes in and they see a persuasive ad, what you're fighting against a moving tide there. How do you handle it? What do you say?
There's all sorts of information out there that's not particularly helpful. Television ads, I think, are really not helpful. Patients occasionally say, "Oh, I saw that drug. That was nice." Most of the time they come in and they say, "What's with this television ad? I see someone dancing and butterflies and all this." And then at the very end, they say, "Well, you may die, you may get terrible infections, you may do this or that. What's the story?" And I tell them to fast forward through the commercials because I don't think they're very helpful. We, on the other hand, have long discussions about what's the right drug for any given individual. And it's not that different from when they come in and say, "Well, I read a book about this diet and people get out of their wheelchairs and walk again." And we again tell them there are good sources for information. Your consortium website is a good source. The National Multiple Sclerosis Society has a good website for information. But there's lots of misinformation. So a big part of our job is to make sure that people are clear and understand the facts.
Well, I think you and I go back far enough to remember the days of the early injectables and how things have changed. I think we've got that kind of history. And I think it's much more challenging for the younger clinician, who's given this huge armamentarium of new medications. I think our history of improvement and watching people improve and seeing fewer people with advancing disability, I think is a very positive message. And I think we just have to keep giving that message over and over again, how the world of MS has changed. Don't you agree?
Oh, I agree entirely. I mean, we were there when we had no therapies. And so being around an illness when it's first and now 20-something, therapy comes out is extraordinarily exciting. And this was the case in '93 when we had our first therapy. And so for neurologic diseases, multiple sclerosis is at the leading edge of neurotherapeutics. And we've gotten very good at bringing these products to market and helping people. And we still have challenges, especially in progressive disease and in repair, but we're developing the skills to tackle those problems.
So if there was one message you were going to give to the clinicians out there and the patients and their families, what would you say in terms of what the future looks like and what kind of hope can you offer?
Multiple sclerosis is an eminently treatable disease, especially for the relapsing forms. And we're working on strategies for treating progressive MS as well. We have some new molecular entities like the Bruton's tyrosine kinase, BTK inhibitors, that are going into clinical trials now. We have studies early phase studies looking at repair of the nervous system using both molecules and cellular replacement therapies, stem cell therapies. So there's lots of interesting and sophisticated research going on that I think makes for a very bright future for MS therapeutics.
So what we have today is a lot of drugs, a lot of hope, and a lot of expert people out there. It's been a pleasure talking to you today, and hopefully we'll get together again in another few months or years and talk about, hopefully, good control and maybe even a cure.
Thank you, June. Happy to be here.